Good day. We are going to have a Mart TV YouTube channel discussion. A lot of people are giving wrong information, misleading information, and a lot of people who don't know anything about COVID virus is talking a lot of giving a lot of information to the general public. So we three thought, okay, let's talk about something that we know to the general public in Sri Lanka and rest of the world. My left hand side, I have Dr. Professor Sarath Gunatilaga, Professor of Health Science from Cal State University of Long Beach. Right next to me on the left hand side, I have Professor of Infectious Disease and Immunology from California University of Health Science and Medicine. And so our discussion is going to be mostly second wave and implication of going back to work, return to work. So I like to get first information from Dr. Professor Dhammika Athapattu. He's going to talk about some brief and also very important information about virus.
Yeah, so viruses are considered the smallest infectious particles for human diseases. So viruses are much smaller than bacteria. What is very special about viruses, as you may know, is that they need a living cell, a living being for their growth, and therefore viruses can be easily killed outside human tissue. So the coronavirus is again of course a virus which is very small, and viruses are broadly categorized depending on the nucleic acids it contains inside the virus. Now this is important for everybody to know that because there are two categories, what are called the DNA viruses and RNA viruses, and the coronavirus is a RNA virus. Why is this important? Because RNA viruses tend to mutate, change the nature of the virus much more than DNA viruses. So therefore the coronavirus, the influenza virus, measles virus, which are all RNA viruses, has the tendency to mutate and create perhaps a new virus which can cause a new wave of infection as opposed to DNA viruses. So now talking about viruses, if you compare the two major viruses which are important for human infections, human disease of the respiratory tract, which is the influenza virus and the coronavirus, the COVID-19 virus, the influenza virus has the tendency to mutate and change rapidly much more than the coronavirus as discovered by scientists in the past 2-3 months. And now is this a good thing? I think it's a good thing because it has implications for developing vaccines. It has implications for identifying how it causes disease in humans, and of course treating the virus using different drugs.
What do you think about this virus? Why is that different from other viruses?
So this is a virus which we believe that was transmitted to humans from perhaps animals in wet markets in China. The genetic studies show that it was transmitted, the virus was transmitted to one single person, an elderly person in China, and then this person had been transmitting to others in China and perhaps to the rest of the world through travel. All viruses are transmitted from humans to humans. Some viruses are transmitted from animals to humans. Example, perhaps this particular coronavirus. So the viruses tend to break the species barrier that causes severe infection in humans And this is particularly important because we humans don't have immunity to those particular viruses which are carried in animals. So when you don't have immunity, you get an infection and you get a severe infection which is transmitted to others very easily. So in addition, they have identified that there are certain features of this particular virus which can cause severe infection, and as the virus tend to multiply inside the cells of the human respiratory tract, they tend to mutate. There are some mutations are small mutations, some mutations are large mutations. Small mutations doesn't seem to really affect too much, but large mutations which they have discovered in the past month or so in a certain part of the virus which is called the spike protein, they have discovered large mutation, 14 large mutations in the spike protein which can cause dramatic infection and change in infection pattern of this particular disease. So we have to be very careful, we have to study these mutations which might help us to predict how the virus is transmitted from one human to the other, and more so in developing vaccines.
Very good. Professor Gunatilaga, I want to ask you one very important question, first question. What do you think about Sri Lanka? That contains this is very well, very limited number of cases and also unbelievably low death level. What is your opinion about that? What do you think about it?
Yes, Sri Lanka has done a great job in controlling the pandemic in Sri Lanka, what we call flattening of the epidemiological curve. That means in most, even in resource rich countries like Italy and Spain, they have not been able to control the disease, and it has really overwhelmed or overtaken the capacity of the health systems to deal with the virus. But in Sri Lanka, we have been able to contain the virus. For example, and the government, the health services, with the collaboration of the health services, the armed forces, the army, navy, the police, and everyone else, with of course the direction of the government, Sri Lanka has been able to control the viruses to a significant, the pandemic to a significant extent. For example, the first case of coronavirus was discovered from an imported case. That means somebody who came from China, lady who came from China, was discovered on January 27th. So from that time onwards, we only have 1,884 cases and 11 deaths. This is a very significant achievement in comparison to most other countries.
I have a very important question to ask Professor Gunatilaga. Sri Lanka, where we are coming from, we have unbelievably low number of cases reported as well as unbelievably low number of deaths. We are very happy, very glad. Can you explain the reason why we have so many low numbers of deaths as well as cases?
One of the main reasons why we have had such a low death rate in Sri Lanka is because the coronavirus affected a relatively younger population in Sri Lanka than most other countries in the developed world. You know that if you consider, for example, United States or UK or some other Italy and some of the developed countries, most of the deaths were in the age group 65 plus, and mostly in nursing homes and places where older people were congregating in smaller spaces, and they also had a lot of underlying medical conditions like diabetes and hypertension. But in Sri Lanka, just to give you an example, about 40% of the cases came from the Valisara camp, where it affected most of the soldiers, and they were relatively healthy, younger people between ages 40 and 6, actually 30 and 60. So in that population, the death rate is extremely low, and also Sri Lanka was able to manage these cases pretty well, in the sense they immediately converted 24 district hospitals into what they call COVID centers, where they could accept the patients and treat them very successfully.
This is my evaluation about why we have so many cases in this country. Lot of people in this country, my patient as well, they're very old, in 80 plus, 90, 100, 80, 90, 100. And not like in Sri Lanka, any other country, United States, seniors are very active. They travel a lot, they go on cruises, they go on trips, they play badminton, they play tennis, they play hockey or whatever. They are very, very active group of people and seniors. They are like, once when they retire, they don't stay home. In Sri Lanka, when they retire, they will stay home, school teacher retire or bank officer retire, they will be taking care of your grandchildren, confined to their homes, staying home. But here people, when they retire, they act as adults again. So once when they have the cases in China, almost all of them traveling from New York, there are major airports in New York, LaGuardia and Newport, Kennedy Airport. Large number of people came from China to America, and we got like bombarded. City was bombarded, trains, subway trains and traveling, taxis and everything. They could not handle that much of patient population. It went like a tsunami, wildfire. And from the beginning in this country, we made a biggest mistake. So many voices, so many people came to the picture giving advices about how to handle this one, what is coronavirus. People who don't know anything about medicine, business people, media people, unless it is people that were in the industry, movie industry, they gave their opinion, and then people were misled. That's the reason why we have so many cases in this country. Professor Athapathu, do you think we are going to have any kind of vaccine in near future?
Yes, so coronavirus, COVID-19 is a vaccine preventable disease. That's what we believe. Vaccine is perhaps the best way to prevent the infection spread. So currently there are 10 which are being evaluated clinically, and out of those 10 I should mention 2 vaccines. One vaccine is mRNA vaccine. It's a vaccine which is made from the genome of the virus. It will be perhaps marketed by a company called Moderna, and in collaboration with National Institutes of Health. The other vaccine is a non-replicating viral vector vaccine researched by University of Oxford and AstraZeneca. So those are the 2 vaccines which I would like to mention, but there are 8 more vaccines. Now those 2 vaccines we believe will be marketed within the next 6 to 8 months, and the current data shows that the Moderna vaccine, the mRNA vaccine, gives substantial protection in the 60 humans they have tried so far. So are we going to have a vaccine? Definitely we are going to have a vaccine. Is it going to be efficacious? Is it going to be a good vaccine? I think it's going to be a good vaccine, and it could prevent the transmission of the disease. Will it be available to the whole population across the globe? That I don't know, but because production of the vaccine is a very challenging thing, and availability, especially in the developing countries, might be a problem. But eventually, we will have a vaccine. Is the mutations of the virus going to affect the vaccine? Perhaps not. They think that the small mutations might not have major implications in developing a successful vaccine.
I want to find out the vaccine. When you come to vaccine, now if we develop vaccine this year, that vaccine going to be effective next year, or every year we have to give like flu vaccine?
No, so as I said before, compared to the flu, the rate of mutation of the coronavirus is very low, is considerably low. So we don't anticipate a huge shift in the antigenic properties of the virus. So therefore, people don't anticipate changing the vaccine every year, but who knows, it might happen, only time can say what it could be.
I know we are doing very good in Sri Lanka. I can see people are putting masks and whatever they have at home, hand washing, even every single railway stations too. Is there anything else we could do in Sri Lanka, as well as what can we learn from Sri Lanka that we don't do in these developed countries?
Yes, it's an excellent question. First, let me look at the factors that were responsible for effective control during this phase of the pandemic. That is, the main factor is, number one, Sri Lanka has a very well structured public health system and a well trained public health workforce. Now, that workforce was combined with the efforts and the power of the army, navy and the police. These forces got together and created, number one, a lockdown which was very effective, tracing all the immigrants who came. Most of the cases were imported from other countries, immigrants, Sri Lankan immigrants who came from other countries, and few tourists, and they traced these contacts, any person who tested positive, they traced these contacts, and they even used the army intelligence to complement the public health epidemiological intelligence system. So this is a very, very effective combination of all available forces, and that did not come as a just by chance. I was a consultant for the World Health Organization in 2004 tsunami in Hambantota, and I could see how the public health workers, the healthcare workers worked closely hand in hand with the army, with the navy, with the police, and we have that experience, and that was one of the worst disasters we had in Sri Lanka, resulting in almost 34,000 deaths. So we had that prior experience which was applied to this situation very quickly, and we took measures very quickly before any. Now, for example, Italy, Spain, US, all these countries applied the same stringent control measures, but that was only after they reported 10, 20, 30 deaths of the deaths after the epidemic. Sri Lanka did it very early, and they did it very effectively. They had a mechanism and previous experience for doing that.
I want to talk about case management a little bit now, clinical management. In my practice, in one nursing home alone, about 250 beds capacity nursing home, I have about 40 COVID positive patients. I have another nursing home, 300 bed capacity, also 45 patient COVID positive patient. My outpatient practice, I have about only 10 patients. They are doing well now. I have 3 patients, acutely ill patient, intubated, 2 of them intubated, 1 actually passed away. Management wise, a lot of doctors even now here in the US learning. None of them know really this is all about. They are experimenting. Some people say early intubation of patients is very important. They have to put the patient in the machine. Some people say no. Some people say give high pressure oxygen treatment. Some of the doctors would say let's give intravenous heparin at the beginning. Some people say no. So I could trial and error kind of business. We discuss among doctors about cases. Everybody has different ideas. The basic information most of the people, most of the doctors gather and agreed upon is early intubation, giving intravenous heparin and remdesivir, 200 milligram IV first day and 100 milligram once a day. And also when they are discharged, if they get better, we have to send them home with some kind of medication called Eliquis and make sure blood pressure is controlled and other medical problems that patients are having under control before they get discharged. But outpatient basis here, just because they have positive cases doesn't mean that patient need to get admitted to the hospital. Keep on calling the patient, have a very close contact, telephone contact with the patient to find out how they are doing. If they are having shortness of breath or high fever, severe body aches and pain, then we are advising them to go to the hospital. But most of the people outpatient, they are not quarantined in centers, but they are confined to their own home and with very close supervision as well as contact with the doctors like us. So we communicate with them very well. So the case is not over. We still have a huge pandemic, especially in California and Arizona. And I would say people are talking about second wave. So I want to ask Professor Dhammika Athapattu about second wave.
So second wave is something which the medical population is predicting, which we might encounter in the near future. Second wave is actually man created. It is thought that second wave is due to moving away from the preventive measures like using masks, social distancing, and basically careless behavior, which increases transmission of the virus between people. Now, could some also predict the possibility of the second wave during the flu season, because they think that the coronavirus and the flu virus might coincide or co-infect people who are not immune. That can cause a huge upsurge of respiratory tract infections. That's possible partly because firstly we don't have a good vaccine for the coronavirus. Secondly, the vaccine we have against the influenza virus is about 40 to 50% effective. So efficacy is all for the influenza virus is also not all that good. Combination of all those factors people think might be the reason for the second wave.
In my practice, I did my postgraduate in New York City, one of the busiest city, and large number of patients. Even a regular day, we have thousands and thousands patients come to the emergency room, get admitted for so many sicknesses. So this corona thing, actually it's like went up at 10 times of population that we usually have in a big city like that. Now Sri Lanka, in case if something happens like that, do we have enough manpower, enough ventilators? Are we equipped with that kind of supplies in our country? I'm going to ask that question. I'm going to ask Professor Sarath Gunatila.
Yeah, when we talk about these second waves, we have to distinguish between a major mutation, as Professor Athapattu was talking about, in which case everybody in the community will be non-immune and they will get it. That is more unlikely than what we are going to experience with this return to work or opening up the economy when we have relaxed the curfew and all these other containment measures. So what you would see is not just one second wave, you would see in the community multiple second waves. Sri Lanka actually is facing many challenges here. Number one, we are returning thousands of immigrant workers from the Middle East and from expatriates from other countries, students and other workers. So there is this whole idea and necessity to quarantine those people. The second thing is we are also reopening the economy and starting things in the workplace, and for which we should have a definitive plan where we can't do things as we used to do before. This is what they call the new normal, where they will have to now think of every employee and decide these employees can work from home, these employees can come to work for a couple of days, these employees are essential. And once they come into the workplace, then you still have to stagger the work so that there are so many shifts, and you need to get people to work in groups and make sure that when you come into the workplace that there is a temperature check, there is a symptom check, they wear the proper protective equipment, the mask, which is known to reduce the spread of infection. And there is also this question whether the cloth masks are effective. Yes, it is, but the effectiveness varies from the quality of the material that's used and the fitness of the mask. So, but if it is well fitted, made well, the cloth mask can provide anywhere from 40 to 70% protection. But the key here is for the workplace to combine that with social distancing, spreading the work area, containing certain groups of workers to one area, and then giving them all the necessary instructions, making sure that there is no unnecessary congregation of workers, and that they disinfect the place very carefully and make sure that there is a mechanism for them to report any kind of symptoms, and it also will have to be followed up by further testing, and of course then at that point you need to initiate the same control measures that the country is taking right now, that is to quarantine and isolate some of these individuals and manage the contact tracing extensively, exactly like what we are doing. So this is not the time to relax, this is the time to be more vigilant.
So I think we have very successful discussion about this and pandemic and second wave. I really appreciate to coming today, Professor Dhammika Athapattu and Professor Sarath Gunatilaka, and thank you. We like to have more and more discussion like this in future. We want to give something to our people in Sri Lanka. Honestly speaking, now look like they are doing extremely good, but if they need anything else from us, we are more than welcome to request any financial help and medical supplies or anything else they need. Thank you.